step aside, is that healthcare disparities knows no bound, and every benchmark that we presented, our biggest referral base for cancer work is through primary care setup, and cancer patients do get pregnant, and one of the focus of cancer care is incidence, new diseases, prevalence, all existing diseases, morbidity, mortality, death, and cancer-related health complications, as in OB complications. A big aspect of cancer care is survivorship. After we beat cancer, we got to continue to live, and quality of life is important, or else the question speaks to what's the point. The burden of cancer or related health conditions. So people who survive cancer do have other health conditions, and we have to coordinate the survival with respect to disparities have been highlighted. Breast cancer, prostate cancer, and myelomatous diseases is taking my family apart. So that those two I do understand well. Cancer disparities can also be seen when outcomes are improving overall, but the outcome is not benefit aspect of society. We often speak to race as the highlight when it comes to healthcare disparities, but the reason we have the American Disabilities Act is to try and mitigate issues pertaining to disparities. There's disparities related to gender, geographic location, income, education, and some other characteristics. These are some of the risk factors associated with disparities, genetics and biologic. And with respect to cancer, this is the next phase of development. Healthcare access, we beat that one up until all the time. Socioeconomic factors comes without saying, environmental, and physical and diet speaks to lifestyle. The minority, racial, ethnic groups are more likely to be poor, medically underserved than whites, and have limited access to health care, and all these factors contribute to the disparate availability of health care. This next few slides goes back to the Institute of Medicine report that was published almost 15 years ago, maybe longer, where in internal medicine, we see the incidence of stroke, mortality related to strokes, prevention of strokes, and treatment of strokes is disparate when it comes to the underserved community and minority communities. In general surgery, this was a big topic in the day, as is maternal fetal outcome, where we see a higher incidence of leg made eligible for kidney transplant. There's a clear disparity in the minority community. In surgical oncology, blacks are less likely than white to undergo cancer surgery for solid tumors. Blacks have a higher rate of death from cancer than whites, despite the overall decline in survival in this country. And we have some of the best technologies available to us to treat these diseases. But that said, the reasons for the disparity is multifactorial. Some of it has to do with what we see in societies. Healthcare systems are becoming fewer but larger. And when that happens, it creates an intrinsic vulnerability as it relates to access. Providers. I may be getting ahead of myself, but with respect to providers, there are many healthcare systems that does not display diversity with respect to providers as it relates to the population they serve. So that comes with its own intrinsic biases. Patient-related factors, we've beaten up on these factors over and over. There are cultural biases as it relates to religion, etc., educational, socioeconomic, and geographic barriers. So with respect to the cancers that I treat most commonly, there are three. Endometrial are cancer of the uterus, ovarian cancer, and cancer of the cervix, cancer of the mouth of the womb. One is the most common gynecologic cancer. One is one of the most lethal cancers across the board. And cervical cancer is probably one of the most preventable cancers there is. So that said, disparities in gynecologic cancer care and outcome between Black women and white women need to be addressed. Just look at these three cancers. Yes. And the incidence overall is about the first world treatment of ovarian cancer in women. And subsequent to that, several large databases were evaluated. The one that's most important to me is looking at the appearance of the National Comprehensive Cancer Network guidelines, which the guidelines looking at over 45,000 patients. That's with ovarian cancer, you can see the incidence in white patients is much greater than Black patients. And when we look at adherence to Nchc, the demographic characteristics independently is associated with a higher likelihood. We realize that Medicare payer status and not the insured status was independently associated with a higher likelihood of not receiving NCC medicaments. And personally, the reason for that is authorization. Many of the private payers require authorization to treat these patients, and you have to furnish the data. With Medicare, it's what you recommend. And as long as it's studied and it has reasonable phase 2 outcomes, it generally gets accepted and gets approved. And what's interesting is how you control for disease and treatment-related variables. Race and socioeconomic predictors of survival for Black race, and not so much the insured payer status. So that's interesting. So when you take into consideration who paid for services, clearly race is a mitigating factor. I'm going to skip this slide because my approach to this talk was I did a meta-analysis of all the studies that I could find related to racial disparities. When it comes to treating ovarian cancer, surgery is the hallmark. We know by several GOG trials that patients who have optimal site reductive surgery, what that means is when you remove all tumors that one can safely remove, the outcome is much better. And when you look at the surgeons who do these surgeries, 97% of them are G1 oncologists in most institutions. In some institutions, about half the doctors are general G1, and in some of the other secondary institutions, 35% of these cases are done by general surgeons. In a study of factors associated with diagnosis of early disease, now the importance of this is patients with early ovarian cancer, the overall survival rate is over 95%. Black women are less likely to be diagnosed with early ovarian cancer than white women. And the reason for that is sometimes the symptoms are very vague. And similar in primary care, when we talk about incidents of myocardial infarction, we don't take the symptoms seriously. I'm going to skip this one. The ethnic and racial minority and poor people are less likely to receive the surgical treatment or care by a high-volume surgeon. It's very clear that high-volume institutions, high-volume providers have better outcomes. The question begs to how do you define high-volume providers? All right, that's a different conversation. Thus, the lack of access to qualified providers clearly impacts outcome in these patients. When you look at advanced ovarian cancer, the majority of patients with ovarian cancer present with advanced disease. Standard of care for advanced disease, like I mentioned before, requires aggressive surgery and platinum-based chemotherapy. And subsequent to that, routine and aggressive follow-up. But similar to those findings in early disease, Black women are diagnosed with advanced disease were less likely to receive the standard of care, which is aggressive surgery and chemotherapy. When you look at underlying comorbid conditions, in the underserved community, you have a higher incidence of hypertension, diabetes, and so on and so forth. And these factors do impact who and how aggressive the intervention becomes. So that said, many women get a percutaneous biopsy and chemotherapy, and that's all they get. When really what they need is aggressive surgery and aggressive chemotherapy. So when you look at disparities in outcome, when you level the playing field, it's very clear that when you take away all these biases and you look at the disease stage to stage, the disparities dissipate. And there's one interesting study done in the armed forces that speaks to this when we talk about cervical cancer. And what's very clear is that when you adhere to evidence-based medicine, as it's in something as simple as the National Cancer Comprehensive Network guidelines, which is available to everyone, the disparities narrow, the gaps narrow. Uterine cancer, which is the most common GYN cancer among women, and interestingly, the most aggressive type from a biological perspective occurs in African American women. The incidence is quite high, almost 50,000 new cases a year, about 8,000 deaths per year. When diagnosed at a local or regional stage, the 5-year survival is very high, 96% and 67% respectively. So when it's confined to the uterus, the survival rate is almost 100%. When you look at the age-adjusted incidence of Black women, it's almost 22 per 100,000, and when you compare it with white women, it's almost 25 per 100,000. So the incidence is higher in white women than in Black women. But when you look at the survival rate among the two groups, Black women are 7%. Their survival rate is 7% less than white women. That's for all stages. So the age-adjusted mortality rate is twice as high, 7 per 100,000 compared to almost 4 per 100,000 when you compare Black women to white women. Multiple studies cite various reasons. Some of those reasons we talk about during the introductory phase of the talk. But Black women of socioeconomic status were more likely to present with advanced stage disease. Now that's across the board. And one of the reasons for that is intrinsic in the biology of the type 2 uterine cancers. And they're very aggressive and they progress very rapidly. Again, the comorbid condition does speak to what happens. The big risk factor in uterine cancer, especially the type 1s, is diabetes and hypertension, which is much higher in low socioeconomic groups and in African American women. To have diabetes and hypertension, and that speaks to some of the intrinsic risk factors. However, the effect of comorbid conditions, when you account for all of that, when you take hypertensive diabetic white women compared to hypertensive diabetic Black women, the disparity gap decreases. These are a couple of studies looking at Black women versus white women that show that African American women are more likely to be treated in high volume urban centers for uterine cancer, which is a little bit different for ovarian cancer. And when you look at how these patients are treated, the incidence of having adequate surgery is equal when treated in these institutions relative to white women, but the survival is much less. Looking at myself in the mirror, I presented a paper in Portugal last year at the International Uterine Cancer Society meeting, looking at the use of advanced technology in the treatment of patients with uterine cancer. And it was clear that Black women, in my own study, is 15% less chance of being treated with advanced technology, as in the robot. Now, this may be related to the stage at which they present and some other comorbid condition, but nonetheless, it is what it is. In terms of standard of care, we need to decrease that disparity gap. This slide speaks to when I talk about aggressive histologic type. papillary serous clear cell carcinoma sarcomas, uterine sarcomas, these incidents are disproportionate among Black people. And these cancers, when you look at the survival database, these high-risk histologic type worsens with age, and regardless of stage, they're very aggressive. The median time to survival for stage 1 with one of these is 18 months, despite what you do. Disparities in endometrial cancer outcome persist. After adjusting for socioeconomic factors, treatment environment, and the molecular basis for aggressive tumor biology often speaks to why it's so disparate in our community. I'm going to skip through this. These are just some of the meta-analysis of some of the slides, some of the studies that were done that just highlight that disparity exists. But this is where medicine needs to go. And this is as we learn to map the genetic profile of individual patients' tumors. I think this is where we will make the most influential change, in that your tumor and your tumor, even though they're the same histologic type, have their own unique biology based on the genetic overexpression. So let's talk about the preventable, because this is where institutions like your community is important, and that's cervical cancer, which is the most preventable. And we see the incidence there. It's the second most common cancer in women worldwide. In this country, we have about 275,000 deaths annually. That said, effective screening, we beat up on the pap test for years and years and years. We did 2 slides, 1 slide, liquid-based, doesn't matter. What's clear is, with respect to screening, there is very little disparity between the two groups. However, with respect to the follow-up, okay, Black women tend to follow up less. So now we need to move from screening to prevention, and that's where vaccines are important. And we have 2 phases of vaccines out now, and we all need to speak to the utilization of vaccines to prevent cancer burden, okay? We see here, this is one study that looks at the SEER database, that look at the incidence of cervical cancer, 8 per 100,000 versus almost 10 per 100,000 when compared Black to whites, with a corresponding mortality rate of whites being 2.2 versus 4.3 in Blacks. So the mortality rate is twice as high. Let's skip through this. Looking at the same SEER database, the mortality rate, again, I just mentioned before, is twice as high, but the overall 5-year survival rate is 61 versus 72%, which is statistically significant when you look at the incidence of cervical cancer. The introduction of the vaccine is important. This is the data that shows that when it looks at initiating the vaccination process, there's no difference. But when it looks at completing the entire sequence, white females are more likely to complete the sequence over Black females. When you look at per capita income per family, we know that poverty is an independent predictor of compliance with adolescents living below the federal poverty line, having a significant lower vaccination rate relative to household incomes of greater than $75,000 annually. Black adolescents were